Bismillahirrahmanirrahim. I hope you can, I hope I'm audible and you can
Yes,
see
sir, you
the
are audible.
presentation.
Yes, sir, you are audible.
Okay, thank you. Assalamu alaikum. Thank you for the kind introduction. I would like to thank and appreciate Dr. Salwa and management of the Shifa International Hospital for providing me an opportunity to speak on a very important and burning issue of pharmacy education, on which the Shifa Tamil Millat University and the Shifa International Hospital are already working hand in hand, mashallah, and doing good in it. I was delighted to hear and see Zishan and Dr. Farooq after a very long time. So I'll just start with the presentation. The topic is basically the indispensable paradigm shift in pharmacy education, which is required at the moment in our country, especially. So whatever I'll discuss today would be with special context to whatever is happening, what is the current status, what are the needs, what are the anomalies in pharmacy education in context to Pakistan. Dr. Asim Rauf very rightly mentioned that there is a distrust in the profession rather than the trust, which is the theme of World Pharmacist Day this time around. And that is basically owing to the lack of information, misinformation, lack of recognition, so on and so forth. I would like to agree with Dr. Rauf as this distrust shall continue unless we do something towards the correction and alignment of pharmacy education, which lies at the core grassroots level in developing a practice-ready pharmacist. So it basically all boils down to lack of outcome-based and structured training and education for the development of a practice-ready pharmacist, apart from other factors as well. So just a brief outline overview what I'll be discussing. So these are the few 6 or 7 points that would enable us to identify the need for change or paradigm shift in the pharmacy education and how it can be done in our setting, in our national setting. So first of all, we need to identify the anomalies that are existing in the current pharmacy education system. We need to identify the anomalies in the current professional practices as well, especially those practices which sort of go hand in hand with the pharmacy basic education system. And once those anomalies are identified, we can move towards the alignment of the curriculum towards a practice-ready pharmacist. Now, practice-ready pharmacist, unfortunately, there is no particular definition of what a practice-ready pharmacist is, what the characteristics of a practice-ready pharmacist should be in context to our country. Then there is the development of policies which can enable the paradigm shift towards making a practice-ready pharmacist, the identification of the missing links between the curriculum that we follow and how we can bridge the gap to produce a practice-ready pharmacist. And then there is the larger task of developing the integrated contextual modular curriculum in pharmacy education, which is a need of the time and is the best practices and guidelines throughout the world, especially in the developed countries. So I'll start with the anomalies that are in the current pharmacy education system. I've been serving in academia for the last 21 or 22 years, and this all comes from my personal experience in serving on top management positions in various pharmaceutical institutions imparting pharmacy education. One of the foremost things that I feel lacks is the absence of a curriculum altogether. The objective outcome-based curriculum is something else, but there is no curriculum of pharmacy in Pakistan. So when I talk about curriculum, we do have a curriculum which we call it a curriculum, but it is unfortunately not a curriculum. Curriculum has a very precise definition, which I hope you can see on the screen here as well. It is it's a sort of a mixture of the instruction modalities that you might adopt for teaching K-12 level students. It comprises of various assessment tools. It has different modalities to integrate different concepts and subjects. So the curriculum has a very holistic approach towards a problem and identified outcomes that could be achievable. The curriculum that we have that is dictated by the Pharmacy Council of Pakistan, that is unfortunately not a curriculum, as it only highlights the contents that should be taught during the 5 years Form D program. So it is basically a syllabus. I would call it a syllabus with very prescriptive assessment methods defined in it. So first thing is to realize and understand about curriculum. I cannot go through the whole concept of curriculum. It's a very long debate, and I don't have that much of time over here. So I'll just briefly tell you that we need to have, the world is moving nowadays, academia is moving towards OBE, we call it the objective-based education. Instead of the previously adopted CBEE, which was the content-based education. So objective-based education is always objective and outcome-oriented based education. And the first and foremost thing is that we don't have a curriculum at the first place, and then we don't have an objective-based or outcome-based curriculum in the first place. The syllabus that we have, that we're following, that all the institutions in Pakistan are mandated to follow, is outdated. There is, during the teaching methodologies, there is an isolated academia-centered design and delivery of the content, which does not, it means that it does not talk about the practice that is being adopted in pharmacy. It is totally, it revolves around research, and it revolves around publications and that sort of things, which I think is incomplete without realizing the actual ground realities and needs of the country and the profession. Fourth is that the syllabus that we follow and the teaching modalities and assessment modalities that we follow are focused on the cognitive skills only. That is the remembering concepts and reading it out. While the psychomotor development or the skill development and the attitude development, or we call it the affective domain, that is not being touched at all. There is a limited psychomotor development in terms of clinical training, industrial exposure, lab trainings, but again, that is very limited because it is not being linked properly with the cognitive skills. Then there is the lack of trained educators, the teaching faculty. There are no faculty development programs, no teaching methodology workshops being adopted, no continual pharmacy education workshops in the field of academia. There is a lack of financial resource and commitment by the decision makers, because when we talk about proper clinical training, you need to have proper hospital clinical affiliations, and not only just affiliations, such affiliations where practices are implemented properly. Then there is the imposition of a single national curriculum by the regulator for all the institutes and settings. Then there is the absence of a mandatory internship and pre-registration exam. I think pre-registration exam is something that I can speak all day long. This is the most important thing, especially when you're dealing at the end of the day with the patient. Pre-registration exam is done globally everywhere, and recently, very recently, the task force on health approved the pre-registration exam for both doctors and even nursing. So I hope they'll start it. I don't know what on what conditions we are on with the pre-registration exam. The mandatory internship is mentioned in the curriculum imposed by the Pharmacy Council of Pakistan, but it is not properly implemented. Faculty apprehension to adopt the lack of curriculum leadership, and lastly, the lack of acceptance of educators and even the educational management's role and their focus on core focus on just publications. These are the few problems that I've highlighted over my past 2 decades of experience in education. Then there comes some anomalies which we can talk about in terms of pharmacy practice, which actually bridge with the pharmacy education. So first and foremost is the lack of acceptance of the role of pharmacist among other healthcare provider. And it is not something to blame to the rest of the healthcare provider. Rather, I would say it is the responsibility of the pharmacist and the teachers, the academia as well, to enable a pharmacist to become a key player and recognize him or herself as a healthcare professional. Why there is a lacking in this recognition? I think it is because of the lack of proper pharmacy education and proper training of a pharmacist. Then there is the lack of requirement of continued professional development or continued pharmacy education for renewal of registration. So like we have renewal of registration after every 5 years, I think, and there is no such requirement for renewal. I think it should be in place. Then there is the lack of a patient-centered approach, lack of need of pharmacy specializations, lack of integration of newer technologies and protocols into the curriculum, lack of professional fraternity, the illegal proxying, the renting of categories, availability of alternate cheaper options by the employer, and the lack of community integration due to profiteering aims. Profiteering is not a bad thing, but there is basically a lack of professionalism. If there is professionalism during profiteering, I think it would bring recognition to both the role of the pharmacist and the profession. Once these anomalies are identified, the next step would be to align the curriculum towards a practice-ready pharmacist. This pyramid that I have drawn, this seems to be a very simple one, but it basically defines everything. It's in a nutshell and has very intricate details behind each and every word that it carries. So basically, when we talk about curriculum development or curriculum implementation or assessment and linking it up to bridge the gap between the academia and the industry, the main first and foremost step is to develop it, to implement it, and to review it. So it's a cycle where you develop a curriculum, you discuss it with the industry specialist, you sit down with them, you implement it, then you review and re-review it and revise it with the industry experts, and the curriculum keeps on evolving around the current trends and the latest trends. Then there is the pharmacist with the workplace specific skills. So basically, in this pharmacy education, there are 3 main components. You need to develop the knowledge, you need to develop the attitude, and you need to develop the skill. These are the main 3 domains of education. We call it the cognitive domain with the knowledge, the psychomotor domain with the skills, and the affective domain with the attitudes. So these 3 things need to be incorporated properly throughout the curriculum in each and every course and topic and training that we conduct to developing pharmacists. And these can be done through challenging and yet achievable contents. And in the current syllabus, the way the syllabus is designed, or the way the education is being done throughout the country, it is not integrated. So for example, we would be studying physiology, anatomy in first year and then forget about it, and then we would study the treatment of a disease, that is the pharmacology, in second and third year, and then the actual disease, that is the pathology, in fourth year. So there is no alignment And there are so many examples like this. This is just one of them. So they are not aligned with each other. They're not integrated with each other. Neither the assessment, neither the instruction. So the three main components are the integrated teaching, the integrated assessment, and therefore the integrated curriculum. And this can all be possible by the partnership with the stakeholders, the feedback from the learners or the students. That is a very important component. This is called the triangulation approach in pharmacy education as well. And then the community and cultural context, the national context that we need to have for our curriculum. It is not a simple task like copying a curriculum from the West, the US, the UK, the Australia, which have different models, different preferences, different problems, different notions of pharmacy practice. So we need to develop all this with context to Pakistan, with the need, and gradually revise it, review it, and refine it so that we go towards some international excellence. Then there is all this curriculum design cannot be achieved without the development of policies. And when I talk about policies, these policies are not only focused to academia, because we need to bridge the gap. So policies, such policies are need to be defined, which not only bridge this gap, but also recognize the importance, their experiences, their experiential learning curves of the practicing pharmacists, our fellow practicing pharmacists in industries, in clinical setups, in hospital setups, in regulatory affairs, in pharmacovigilance, in DRAP, and so forth. So first of the foremost policy development would start from shifting from the content-based education to the outcome-based education. This is the first and foremost and the most important policy. Then there would be developing a faculty service structure for the practicing pharmacist. This is something that we have done in Shifa, between the Shifa International Hospital Pharmacy Department and the Shifa Tamir Millat University College of Pharmaceutical Sciences. Until and unless we don't recognize the expertise, the experiences, the specialization of our fellow pharmacists practicing in practice fields, it is not possible. And by recognizing, I mean properly recognizing them, properly labeling them, assigning them, appointing them as faculty members at par to academic streams in pharmacy education. So what we have done, and I think it is the first time in Pakistan, and I'm proud to pronounce it, that we developed a dedicated faculty structure for practicing stream for the pharmacist. So it starts from instructor and goes through the lecturer, senior lecturer, assistant professor, associate professor, and goes up to the level of professor. And it has different set of criteria, different set of eligibility to become assistant professor in practice stream than compared to the academic stream. So for example, in academic stream, to become an assistant professor or a professor, you might need to have a postgraduate qualification like PhD or MPhil, or you might need to have a lot of publications and so on and so forth. But when we developed this faculty service structure for the practicing stream, we laid down different eligibility criteria which were in line with the practice excellence of a pharmacist, and therefore the structures of AP, associate, and professor. So we are actually we implemented it, we got it approved from the statutory bodies of the university. It is very much implemented in the Shifa International Hospital and the Shifa Tamir Millat University. We have adjunct faculty from the Shifa International Hospital, which is duly recognized and appointed as a adjunct faculty in the university. The third important thing is the faculty development programs and teacher training programs. So this goes hand in hand with the curriculum development and the pharmacy education. Then there is the involvement of all stakeholders. There should be some meetings or specialty centered focus group meetings to discuss on the current trends of what is happening in the respective specialities for incorporation into the curriculum. Then one of the other important thing is that is the award of academic credit in lieu of experiential learning. So this is something that I worked with Dr. Salwa. We had a very brainstorming session, and we studied a lot of universities in the US and the UK and Germany, where people who are working in the practice stream, there is a problem that they are left behind in terms of their academic qualification and academic excellence. So around the globe, this is a very common practice that there is a set standard of experiential learning, and that should be equated and credited with academic credits. So, for example, if a person is working in a practice stream for more than 20 years, and I've set up a criteria, and we have a postgraduate qualification over there in the same field, so maybe we can evaluate the experiential learning that particular practice pharmacist has, and we can equate it with particular credit, so that he or she might not be mandated to take those courses as a part of the postgraduate studies. There would obviously be a fixed residency mandated time in the or during the postgraduate program, but the experiential learning should be equated and credited towards a postgraduate academic degree. So a policy needs to be done on this as well. And again, I'm proud that we developed a very comprehensive and linked policy for academic credits in lieu of experiential learning, got it approved from the statutory bodies of the university, and we're in the process of implementing it very soon, inshallah, within this year. The final thing in terms of policy development is the policies to critically analyze and structure the liaising between the academic and practice streams. The missing link between the curriculum and practice-ready pharmacists. So as I told you earlier, WHO has defined a 7-star pharmacist. So that basically revolves around the 7 characteristics that a pharmacist should have to be a practice-ready pharmacist. We studied it when we were designing our curriculum in Shifa Tamir Millat University. We studied those 7 characteristics and identified 3 more characteristics, which were basically because of the fact that we are lacking and lagging behind in pharmacy education and practice in a lot of fields compared to the rest of the world. So in our college, in our hospital, we have developed it as a 10-star pharmacist. We call it a 10-star pharmacist, practice-ready pharmacist. So the main characteristics of a 10-star pharmacy practice-ready pharmacist is that he should be a team player, he should be a manager, he should be a good researcher, good leader, good caregiver, good communicator, decision maker, a lifelong learner, which is very important, a teacher, and above all, an entrepreneur. So these 10 competencies or core areas, they're just not core areas written on a piece of slide on PowerPoint. We have actually linked these as outcomes to our curriculum, to each and every course. So for example, we have a stream of pharmacotherapy. So pharmacotherapy might be dealing with a few of these 10 areas. Another stream we have of formulation development. So formulation development might be dealing with some other areas. So by the end of the 5 years, any student who goes through our curriculum, after the 5 years tenure, he possesses these 10 characteristics which enable him to become a practice-ready pharmacist. And he does not just possess these characteristics, he earned those characteristics because all of these characteristics are linked appropriately, taught appropriately, and assessed in an integrated fashion throughout the 5-year integrated contextual curriculum. So the core competencies need to be identified and developed. The inclusion of the 3 domains of knowledge, which I told you earlier, are the cognitive skills, the cognitive part, the skills part, and the affective domain. Those need to be incorporated in the curriculum. And then there is the mandatory experiential learning through immersions. So a lot of people have a different concept about immersion, but immersion basically reflects a supervised clinical training or industrial training and leadership programs. So this is something missing in our education, either because of the outlining in the syllabus that we are following, or because of the lack of the hospitals, or because of the lack of the proper pharmacy practices being adopted in the hospital. So it's basically a vicious cycle which goes round and round. So then the most important task that we have achieved, alhamdulillah, is the development of an integrated contextual modular curriculum. We call it the ICMC. So if you can see on your left, you would find that the first year is comprised of the foundation year. So what we do is we cover the foundation topics, because unfortunately after the K-12 education, the FSC or the OA level, the students that come up to us, we need to unlearn and relearn them a lot of basic concepts of biology, chemistry, physics, maths, because either they have not been taught properly, and that is all because of the deteriorating primary education and secondary education in our country. So this is something that we need to take up, but was very detrimental to the rest of the curriculum. So this is a responsibility we have taken up, where we develop the basic concepts in line, especially focusing on the pharmacy education. So 1 year is the foundation year. The next 3.5 years, we have divided it into three main domains. One is the pharmacotherapy domain, other is the dosage form development, or we call it now the formulation development domain, and third, the most important, is the nation building domain, which is in line with the name of our university, Tamir-e-Millat, plus it is basically the focusing on the attitude domain of the student. In a lot of advanced countries, this pharmacotherapy and formulation development is actually taught as a part of the PharmD curriculum as two different separate streams. So people who would like to go to the clinical and hospital and retail and community setups, they would only study the pharmacotherapy domain throughout their PharmD degree program, while the people who would like to go towards research, chemistry, lab work and formulation design and development, they would study only this part during their 5-year program. But when we were designing this curriculum, we consulted and followed the Accreditation Council for Pharmacy Education, US, and we identified that this was probably not going to work in our setting, because contrary to rest of the world, in our country, we have a lot of focus on pharmacy education in terms of job prospects and the industrial aspect. We have, I think, more than 700 industries in Pakistan, and almost 99.9% of them are not automated, fully automated. They're run by pharmacists. There is a huge job market. So we decided to teach both these streams simultaneously, although it is very difficult and sort of a burden both on the teachers and the learner, but it is how it is in the previous curriculum as well, but we have at least integrated it in an appropriate manner as per the guidelines of the ACPE US. So, and in the last 6 months, the 0.5 years of the degree, we indulged our students into advanced student directorship, or we call it the integrated supervised practicum activities, which is an integral part. These activities, by the way, supervised practices are also during the 3.5 years experience and practice part, where we teach them pharmacotherapy and formulation development. We also take them to the practicing part, but this last 6 months, this is project oriented, this is entrepreneurship oriented, this is unsupervised clinical practice, unsupervised industry, and unsupervised community practice. So after this complete 5 years, when the student, the learner, comes out into the market, he is supposed to be properly developed as a practice ready pharmacist, in all the major domains that are required in our as a national need. So this is when we developed this curriculum, we adopted the triangulation approach, in which there are three parts. One is the learner, then there is the instructor, and then there are the professionals from the industry. So we collect data points from the learner, instructor, and professionals from the industry through formative summative assessment, through feedbacks, through quality control feedbacks, through instructions, through participation. So it's a huge process, and we have a lot of data. So since we implemented it, we are also now in the process of comparing it statistically, this system with the conventional semester-based system that is dictated by the council, and rest of the institutions are following it. Coming towards the end, a question I would like to ask everyone over here, the pharmacists from all the areas: have you played your role? Everyone needs to play their part for the recognition, development, and refinement of the missing link between the pharmacy education and profession in Pakistan. So the role everyone can play, the learner, the instructors should play their role, the academia should play its role, the role of the industry is pretty much over there. The role of the regulator is the foremost and the most important. The Council of Pakistan, Pharmacy Council of Pakistan, has very recently taken up this huge task to revise the curriculum and develop the curriculum. They have written to us. We have provided them with all the development of curriculum, the strategies, and the implementation part that we have been doing for the last 2 years, and we'll be sitting with them on educating them and highlighting the key issues on how we can develop it and implement it at a national level. So DRAP and HEC has a very important role in it as well. And the most important role, I think, is of the management and leadership of both the industry. Either it is the manufacturing industry, it is the regulatory industry, it is the hospital industry, and be it the academic industry, and their leaderships. So until and unless we don't have commitment from them, and proper commitment and follow-up by the management sitting in top positions, we cannot go ahead with this part of the pharmacy education. So through this forum, through this small talk, I would request everyone to join hands with us. If you feel an urge to deliberate on pharmacy education in Pakistan, if this presentation, a small brief talk, has enlightened something in your heart to work towards pharmacy education, please do contact us. If you want to explore what we're doing to bridge the academia and practice stream by developing the integrated contextual modular curriculum and actually implementing it at the Shifa, so you can contact us. If you want us to educate you, because this is not something that we just woke up one fine morning and implemented it. It has a working of at least 4 to 5 years behind this. We did our proper homework. We developed this whole curriculum and for its implementation. So if you want us to educate you or your faculty or your university or other such institutions involved in imparting education and developing a practice-ready pharmacist, or at least envisioning in developing a practice-ready pharmacist, we can help you in that to adopt the best international guidelines, the best practices. If you feel the need to collaborate with us for streamlining pharmacy education for the country, not only for your profession, you can contact us. I've developed a special email for this forum so that we can join hands and continue. So concluding this presentation, I would leave every one of you with a quote, a saying by Alvin Toffler, that the illiterate of the 21st century will not be those who cannot read and write, but those who cannot learn, unlearn, and relearn. So these three words are very important when we talk about pharmacy education, when we talk about developing pharmacy education in line with the best practices, developing such a curriculum, such a instructional and assessment modality in pharmacy education, which can probably serve not only our nation but the pharmacy profession as a whole. So we need to unlearn the old techniques of educating, the old techniques of practice, and relearn what is being done in the whole world in terms of imparting education. So I would like to thank all the participants for hearing me out. And if anyone has any questions or any urge to collaborate with us, please drop an email on the email address that I just shared with you. Thank you, everyone.